The other problem with that is, think about where they are, and now, if you wanted to put locators there, those locator housings are gonna be big bumps for the tongue. So, for me, I would move those a little bit more labial.
And again, they're focused on the crest of the ridge, but you really don't know what that's going to look like until you have the tissue reflected, unless you get a cone beam CT scan to look at this across section. And you can pre-plan ahead of time about the length of the implant, but this mandible is so large, I think we have the image up. It's so large that you can go with a 13mm implant, plenty long. You don't have to go with the 16 on this. But you probably could if you wanted to. There's no idea that you have to engage the inferior border. It's just a matter of getting in a reasonably good sized implant. And so if you have the imaging, the health history is there. She had the extraction, I don't know how long ago it said, 3 years or something. Okay. 3 years ago, was treated, she had a myocardial infarction, heart attack, and has mild CVHF with orthopnea. Fine, that's, and again, you can do this under local and clinic setting. These surgeries aren't particularly painful for people. However, you need to warn them, when you make an incision of this length and access the mandible by reflecting the tissue, some of these patients will have fairly significant ecchymosis afterwards, and so you have to warn them that they'll have some swelling and they'll get black and blue. And we've seen some of them, based upon their medical condition, have profound neck bruising that'll last for about a week and 10 days. Essentially the bleeding goes in the subplatysmal plane, and it goes all the way down to their chest. It looks horrible, it turns green and then yellow. Usually it's not painful, but again, you have to warn them that there is a potential for that to occur, so they're not going to be in the public eye for a period of time after. Okay, do you want to go to the next one? Thank you. And so here's essentially showing the mandible with 2 and 4 implants for reconstruction. Again, the 4 implant reconstruction is likely a spread issue. I don't really care. I don't make those placements on that basis. Your bottom left-hand picture is the alveolus before reduction in vertical height. And so the pictures with the implants in place obviously are after the reduction vertically. And so again, you can many times make that diagnosis on the basis of your imaging when you have the anterior region that's superiorly positioned. Now, the other thing that I like to do, and it doesn't relate to the prosthesis, but I mentioned it in the lab or in the classroom, is I try to find the mental foramen. And if you push hard on these models, you'll just push it out of position, but you can feel kind of a bump or a dent. I would anticipate the mental foramen to be there and there. And so just get an idea in your mind where that is. Approximately, so that, and again, you can turn back on the camera, because I guess we're still by tomorrow we'll have this all figured out. That's that. We gotta go back to the camera. Yes. We just don't know which